Hello, everyone. Today we are doing our podcast, and that's my favorite podcast ever that I do with the brilliant and, for my opinion, number one DMEK surgeon worldwide, Dr. Jack Parker. Let's say hello, say hi for him. How are you, Dr. Jack? It has been a long time. I miss you so much. Tell me about what happened since we last met, and how was your Netherlands trip?
Yeah, it's so good to see you always, Hosny. When was the last time we saw each other? When were you here? Remind
It
me.
was last May or something like that. It's like 9 months or something like that.
Amazing how time flies. Well,
Yeah, it is. It is.
it's so good to talk with you again. Yeah, we're all doing great. What you were just mentioning, I'm just back from a trip to Holland where I went to see my mentor, Garrett Mellis. I took my wife and two of our three children up to Holland where we spent a few days with him, which is great. I mean, he's one of my best friends. He's my personal hero. I mean, he's just this incredibly accomplished guy. And it had been a while since I've been to Holland, so it was so nice to go. Even though it's quite cold there, in February. I kind of forgotten how cold it is in the Netherlands in February.
Yeah, I think it's cold here as well, like in England.
Yeah, yeah, indeed. But we had a great time.
That's good. Welcome back, and I'm happy that you have good time. And next time it will be like next Europe visit. You will come to UK, even if it's not European Union anymore, but like it will be London here, and
Yeah,
we will host you here.
yeah, great. Love to.
Yeah. So, Dr. Jack, there's a lot of nice topic today. We will just tell our audience that we have very nice topics today that we are talking about, and we have a video of one of the complications that I did. I learned from you that don't be shy ever to put your complications online, because everyone will learn, and if you put your complications like and see how to solve it, so I will never be shy to do a complication like if somebody experienced like you. But I'll see you how I manage it. And I was just talking to you before the podcast that the first thing to come to my mind, like, what would Dr. Jack do now? Let's start first about the topic we talk about. Maybe you see it in the UKSRS last time, and they're talking about now the other alternatives for DMEKs. So I want to take your opinion about the artificial endothelium now. I'll not talk about the endo art because, like, I know your opinion about. Even some people just will not talking in this podcast. They will take it maybe in another podcast in details about the endo art opinion. But we're talking about now the cell injections and the rock inhibitors, and as well, I remember one when I was in the Cornea bank in Alabama, when I was training with you. They were saying that they are about to invent some collagen sheet, which will be like a DMEK, artificial DMEK, and there is kind of they will put the cells on it and will be implanted, so we'll have like unlimited source of DMEK. So I want your opinion about this.
Um, I have a lot of thoughts on the subject, but I would say, broadly speaking, my opinion doesn't matter. And the reason that my opinion really doesn't matter is that I don't know. I don't know what the future is going to bring. The future is so radically unpredictable in so many ways. The development of technology, who knows what we're going to be doing a few years from now? And one thing that Garrett told me just a couple of days ago when I was in Holland is he said with all of these new endothelial proposals, these different types of surgeries, cell culture and injection and various different scaffolding sheets that cells are splayed across and put into the eye, what he said is that he's very reluctant to say anything negative about any of them because when he was inventing endothelial keratoplasty, DSEK and DLEK and DMEK, everybody told him, well, none of those things will work. And not just random regular people, but really impressive scientific minds, accomplished surgeons, people who are preeminent in the field. And he said that, well, he just remembers personally that it's not nice to have other people say discouraging things about your work, and it's very difficult to know what sort of things are going to be successful, even if you're very smart and at the top of the field. So, because he didn't appreciate people sort of poo pooing his innovations, he always tries not to be that role for somebody else. He doesn't want to say, well, that's not going to work, or you're making a mistake, or you shouldn't work on that. And that was very inspiring for me to hear, that we can have our own opinions, but it's probably improper to discourage anyone on their various research paths. So I thought that was a very elegant way of expressing that idea.
Yeah. So, but you think at some stage after all this demic training and stuff, we just will stop doing demic and we stop this fun?
Well, I remember when Kinoshita made his AAO presentation on the subject of injectable endothelial cells. I was sitting in the audience at Cornea Day at the Academy, right next to Garrett. Garrett was sitting immediately to my right, and Kinoshita is presenting, and I look at Garrett over here to my right, and I'm just thinking, like, is this going to destroy DMEK? Is this everything that you've produced? It's all gone, because now it's been superseded by some new technology. And what Garrett said is, well, maybe we'll see, And that was 10 years ago. And cultured cells may really work. That really may be the next thing. Maybe we are all going to start doing that instead of DMEK, or some other thing instead of DMEK. I mean, certainly eventually there'll be something else we're doing. But I was afraid it was going to be tomorrow, 10 years ago. And here we are 10 years later, and it doesn't look like anything has really changed. It might be another 10 years. It could be in 6 months. It could be 15 years. It could be some new technology that we haven't heard of that's not on the horizon now. So the future is radically unknowable. All you can do right now is the best you can do. The best we have right now, the best I'm able to offer my patients right now, I think, is DMEK. So I'm planning on continuing to do that for now.
Yeah. So yeah, I agree completely with this. Nobody knows what the future will going, and still, like if there's something new, I think we are all open for, and I think you will be like one of the pioneers in it as well. Like you'll not let somebody.
Well, I think the
Yeah.
great fortune of my life actually is to associate with so many tremendous people. What I tell people all the time is I genuinely don't think I've ever had an original idea in my entire life. I think every idea I've ever had has come from somebody else, and it's just been the greatest blessing and fortune that I can express to talk to so many creative, wonderful, smart people, including you, Hosni. So if there
No,
is
but
some
thank you very
brilliant
much,
thing in
Dr.
the
Jack.
future, I highly doubt that I'll be responsible for it, but I will try to appreciate the wonderful intellectual gifts of my colleagues.
Well, I think, like really, Dr. Jack, I've learned a lot from you. Like you influence myself. Even like when you come to London, and we'll see. Like I always talk how much I learned from you, um, and how much the energy like I got from you. Like I learned from you the energy and the enthusiasm and working like as a leader. Right leader that people all like you, so like I've learned a lot from you, and thank you very much for this, and I stay learning, stay still learning from you.
Well, probably influenced us when you visited as much as we influenced you. I mean, you're just such a pleasant, friendly, enthusiastic person to have around. I mean, I thought you just fit in super well here, and it was just great having you, frankly.
Thank you very much, Dr. Jack. So the next one, before just we talk about the next topic, I want to show you a video for the surgery that we did. The thing, let me just play it first here. So we started first with peeling because like we don't have the luxurious things that like you have like with the preloaded
Yeah.
DMEK that you have, and just we do the surgery, we do the peeling, we stain. So the first thing, this was my a new completely new setup for me, so that's why it was a little bit, I find a lot of things just coming. First of all, I don't know why I sit on top. I never sit on top in Dimic, like, but I sit on top, uh, and don't ask me why. And I choose a blade that I never used before. It's 2.8, and it was really unsharp, and it just caused me a panic when it just start to jump. As this, thanks God, it doesn't happen something bad.
Yeah.
And the thing that this patient is like 49 years old and he's phakic. So you have all this kind of shallow anterior chamber, like you have to take care of the lens and all this stuff. As usual, I did your under air technique, which is actually worked very well and improves the visualization. And I think a lot of people will adopt it. Every time they see it, they just say, "Okay, that's that. Why we're still doing it under visco, still doing it underwater, if we have this kind of thing." So that's the thing now. So I was about to finish the peeling, and boom, what happened? All of a sudden, I find that the AC become very shallow and the eye become rock hard. So what happened? Who was assisting me as a brilliant doctor? He was a brilliant fellow. He's very, very good. But this is the first sitting and the first time they use this kind of a plunger to put the air. It seems that he feel a block when this AC maintainer was touching the iris, so he over push, and probably there's a lot of air came in the back of the phakic
Yeah.
eye. So as I told you before the podcast, I start to think. I say you came in my mind like like a guarding angel. I say what he will do, and all the videos come to my mind. All the fellowship that I did with you come to my mind. Then we think. First of all, like what we will do, Dr. Jack, if this happen with you. First, if this complication happened with you before?
I'm trying to think. All the time we encounter air bubble misdirection posteriorly behind an implant lens. If you're operating on an eye that's been vitrectomized already, or that has some kind of scleral fixated lens, or an ACIOL, then posterior misdirection of the air behind the iris and behind the IOL are common. It's not so common to have posterior misdirection of the air behind the phakic lens. I'm trying to think if I've ever had that particular event. Nothing comes to mind, but maybe. I mean, certainly possible to me. And I think you're right on. I think that's what happened here. You can see the sort of abnormal light reflex through the pupil. You can see there's an air bubble back there. And I think likely, it's probably pushing too hard with the AC maintainer through some defect in the iris that caused misdirection of the air. Yeah, interesting.
So what you will do if this happened, like apart from giving out to the assistant? It didn't happen really. Like it happened to everyone, but like what you will do?
Good question. I think what I would probably try to do initially is make an iridotomy far inferiorly with whatever means I had at my disposal, whether it was a vitrector or our little capsulorhexis handpiece, far peripherally, over around the edges where the zonules would be, and see if I can't make some connection between the anterior and the posterior chambers, such that that giant air bubble could pass forward up into the front of the eye. That's what I would try to do. I think to unite the anterior and posterior chambers by making an iridotomy over where the zonules are and to some extent through the zonules. If that didn't work, and who knows, maybe that would fail completely. If that didn't work, then I would do a vitrectomy. I would either put ports in, or I would make a little sclerostomy a couple millimeters behind the limbus and do a vitrectomy with an anterior chamber maintainer connected to fluid, or just the syringe with fluid and the assistant pushing fluid through the syringe, and just the vitrector through the pars plana. That is something that we have done before in these pseudophakic cases. And as a result, this is why I'm always mentioning, I think that DMEK surgeons need to know how to do DMEK in eyes that have been vitrectomized, because sometimes to complete the case, you must do the vitrectomy. Sometimes you must do a pars plana vitrectomy yourself during the DMEK to facilitate the operation. So DMEK in a vitrectomized eye is just a skill you have to build. So just off the top of my head, I think I would probably do one or both of those things. But I'm very curious to know what you did.
Yeah, so absolutely, that's fantastic. First of all, the AC was very shallow for me. I couldn't get inside more,
Yeah.
and I was planning to do this DMEK with no vitrectomy. I just planning with doing the way with the drops, like no, with no vitrectomy, because that's a new setting for me. I need to get used to the settings and stuff. Plus, so I didn't use the vitrectomy. Plus, like what came to my mind? Okay, so what came to my mind is this. So first of all, like I was checking the pressure. Can you see this? Like how hard it is? Like
Yeah, yeah,
it's
yeah,
like
yeah,
a rock hard. So I
yeah,
removed the plunger and
yeah. Rock hard.
I started. I say, okay, I will treat it as if I want to do intravitreal injections.
Yeah.
So what I did is that I started to put the to measure like 4 millimeter from the limbus and put a 30 gauge needle and try to tap a little bit and see how much air will go through. That was the trial.
It looks pretty
And
already. Yeah.
yeah, and there's while doing that, I feel the softness start to happen in the eye, and maybe some bubbles came into the anterior chamber as well. So I start to get it, see how it coming. Probably there's something from the nules or something like that, but it start to easen up and start to, as you can see, being softer. So I say,
That's
okay, the AC started to form and everything goes well. So yeah, so that was happened, and I
See,
started to put the
I don't
graft.
think I would have thought of that, Hosni. That's very, very good surgical intuition there. I mean, I think that's really, really elegant, quick, nice way to alleviate that problem. Super nice.
Thank you very much, Dr. Jack, but it was very scary.
Yeah.
Because like yeah, it's just when you feel the eye all of a sudden became very high pressure. I just follow your rules, like in this, just put it the DMEK. It's a good chance as well to see like uh, form the AC to get a configuration. I get a configuration.
Super.
I started to I say okay, I do a bump up to see it's a bouquet. Bump up, maybe it will show reveal something more. Okay, that's like a rolled edge, and I want to don't waste your time. It finish
Really
as
nice.
normal,
Beautiful.
and just we put the air bubble, and that's it.
Really
So
nice. That was beautiful. Really well done. I
thank
noticed a lot of manipulations through the main wound, which is not, I mean, it takes really great surgical skill to do that. So super nice job.
I this when won't I wasn't daring to do that before I become your fellow. After I become your fellow, I got the gut. I can do this.
Yeah, I mean,
So
that was really nice. The graft was really darkly stained, which is also really, really nice. I mean, it's many people like myself who don't have enough patience stain the graft poorly. And if the
yeah,
graft is stained poorly, then it just makes the surgery needlessly difficult. It's
that's right.
needlessly challenging. And having the graft really well, darkly stained is really very classy because it makes the operation much more beautiful. I mean, the video is more beautiful, and you're just more certain of what's going on inside of the eye. So super nice. Really well
Thank
done.
you very much, Dr. Jack. Like I was thinking you will do the same as well, but for vitrectomy, it didn't come to my mind, to be honest, because it maybe for the facilities it will take a lot of time, and the pressure. I was afraid as well. The pressure, I don't want it to be high for a long time. So thank God it works, and especially
Yep.
with phakic eye.
If
And the
that
good
happens
thing,
to
the
me,
patient
that's
is
what I'm going to
immediately
do.
attached next
If,
day,
if that happens
and
to me, I'm
with
going to do that. Yeah.
yeah, and it was 100% full, probably because the following day, because I think it was keep coming from something from the back, but the pressure was 8 millimeter mercury, and the vision was surprisingly 6/9 with the air bubble. So hopefully, if it should be fine anyway later on.
So the anterior chamber was 100% full the next day.
Yeah, 100% full.
It's interesting. It almost makes you wonder if that wouldn't be a good thing to do on purpose. If it wouldn't be a good thing on purpose to leave some air in the back of the eye such that the anterior chamber can continuously refill.
I won't do that. after I have seen on this day and this anxiety, like this is how I felt like. I was hearing my heartbeat anyway. So yeah, thank you very much for your opinion about this
Well
thing,
done.
and for the about, because I really wanted your opinion about the video and your thoughts as well. So we will get to the next point. Cares. So the cares, like I know that you do like a big amount of the cares manually, and what I think, that's my opinion about the manual cares. It's a great idea, a super great idea, because all people can benefit from this operation, very nice operation that can save them from doing like grafts and have the hazards of the grafts. But and because like if you do it in fem to LASIK, like you need equipments, you need more than just like it costs a lot of money anyway. So but on the other hand, we have some opinions, just saying that manual cares is unpredictable, is unsafe, as it can be very shallow or very superficial, the tunnels. So I want your opinion about it, which I was actually very keen to hear it, because I am very pro the manual, and I feel that it will help thousands of people to improve their vision, and avoiding like unnecessary grafts.
Yeah. Well, I have never myself personally done femtosecond cares. Maybe it's better. I don't know. So it's tough for me to compare them directly. We do a lot of manual cares, and the reason that we do that is because we have not had access to the femtosecond laser for the majority of my career. The hospital where I started my training, they didn't have a laser to make the channel. So if this is a procedure we were going to offer our patients, the only choice we had was to make the channels manually. So that's the way we started with it. That's the way I learned. And I think it has worked out well for us. We do quite a number of them. It's Wednesday right now at the time we're having this conversation. We've got 8 cares scheduled on the surgery for tomorrow. So we do, it's not uncommon for us to do, 8, 10 a day. So we have a lot of experience doing the manual technique, and it seems like a fairly safe thing. Now, with all surgery, there are risks. There's no surgery that's entirely safe that I know of. Cataract surgery is certainly not entirely safe. You definitely can have complications with CAIRS. You can definitely have complications with the manual creation of the channel. I'm sure you can have complications when the femtosecond laser makes the channel. The reason that we have not been feeling the need to switch to the laser is, it's a big expense, not only for us, the clinic, to buy the laser. It's hundreds of thousands of dollars. But it also, the lasers have a click fee, which is typically passed on to the patient. It makes the surgery cost an extra $1,000. That's not something that's affordable for many patients, to make the surgery much more expensive. The other thing is that the lasers that I'm familiar with, I think most of them are applanating lasers. They're applanating lasers, which means, of course, they flatten the cornea to cut through them. I don't think an applanating laser works so well if you have a really ectatic cornea. If the cornea is really ectatic, that when you flatten the cone, you get these undulations in the surface of the eye. And I think it makes it difficult to make a channel cut cleanly through at one level. I think the channel kind of goes up and down like this. So I don't know that the channel depth is really more predictable if you're using a femtosecond laser. Maybe it is, but it sort of makes sense to me that it might have problems. The other thing is that there are comparative studies done on the use of femtosecond laser versus a manual technique for channel creation for intacs. And what most of the papers show is there's not a reduction in complications when you use the laser. There are just as many complications, but they tend to be of a different kind. Like, for example, I think that the channels tend to have more problem with decentration when you're using a laser than as opposed to if you're doing it manually. So, what I would just say to recap is that the procedure seems to go well for us when we're using a manual technique, so we haven't felt the pressure to change. If we do change, it's going to make the procedure much more expensive for the patients. We may not be able to treat all the same number of patients because some patients may be too steep for the laser to appropriately applanate the cornea, and we probably would trade one set of complications for others. So that's my opinion today in 2026. I mean, I'm certainly open to changing my mind, but that's why we do the things we do now.
So while you are live now, I would take a promise for you that we will arrange a big CAIRS workshop in London, in one of the biggest hospitals and the biggest universities. And we will be so honored to have you as the leader for this
Well,
thing.
you're very kind to say that. It's a very flattering offer. Thank you. We have a visiting ophthalmologist with us from Rwanda today. And he was asking me this morning, he said, "Well, you must be the highest volume CARES surgeon in the United States." And I said, "Actually, probably no. It's probably my fellow. But I think my fellow does more than me. I think my fellow is the highest volume CARES surgeon in the United States."
Yeah.
But speaking of which, my fellow's name is Philip Dockery. He's a super smart, great. He's much more naturally talented as a surgeon than me, much more. I mean, to see him doing the things as a fellow now, I was not even close to doing these things when I was a fellow. So it's amazing to be around him. And I think he's planning actually to go to Rwanda in the next month or two to do the first CARES in that country. So super nice thing for him.
That's very. I watch Philip. I become a fan of him as
Yeah,
well. Like, and I met him for a second years before the podcast, and
yeah.
he's really talented, and he's lucky as well. As much as you are lucky to have him, he's lucky to learn from you. But for the predictability for these cares, like, do you feel it's the same? Anyway, cares is not predictable, like even with all this nomograms and stuff. But do you think it's kind of predictable? Like, did you do any kind of an audit for what you have done from things?
Um, when we do CARES, we expect the cornea to flatten. And we expect it to flatten more depending on how ectatic the recipient eye is. The worse the cone, the more flattening you get, because probably the cornea is thinner and more pliable. It's floppier and more amenable to being corrected by a big hunk thick strip of normal collagen. But in terms of how many diopters you're going to get numerically, quantitatively, it's not nearly as precise as something like LASIK or cataract surgery. You're hoping you flatten the cornea enough to make a difference in the patient's vision, but how much you're going to flatten it, we don't really know. And is that a failure of the nomograms now? Maybe, certainly could be. It could also be that the technique somehow needs to be tweaked such that we're able to more tailor the implantation. I don't know, but I do know that CARES 5 years from now will be different than it is today. Certainly, it's different now than it was 5 years ago.
That's right. I have a colleague called Dr. Hatch. He's one of the most brilliant consultants, well, like in the United Kingdom. He's in Colchester, and he do the cares with femto, but he does a paper as a post-operative adjustment with the pentacam. So in the first week, he put a contact lens and start to kind of a milk, as far as I understood from him, the segment. He start to milk it till he got the proper pentacam reading, and that's worked for the first week, and it should be stable after. So I think could be something like this happen. Yeah.
Yeah, I'd be very interested to see that. Certainly,
Yes.
that could be good.
Yes, so I can see. I know that you have a clinic now, and we have spent some time in the logistics for the podcast. So I don't want to take a lot of your time. Just last question: He's one of the colleagues. He's as well working at one of the biggest hospital in Saudi Arabia, and when he knows that I will be talking to you, he asked me about. He got a case with Ahmed Valve, and when he talked to me about the case before he do it, I tell him like what Dr. Jack do. You have to cut the tube, otherwise it even not even touching is just a fluidics. It can affect it. So the strange thing that I want to take your opinion of first, like he was asking about the tools. He couldn't make it, even if he's like a very good surgeon. He says it always slipped from him when he was cutting. So can you tell me what is the tools you use for this, like the instruments for?
All of the lessons that I've learned have been learned the hard way. Every single insight that I have is painfully acquired, I'm sorry to say. And I think when you're cutting an Ahmed tube, there are, or a Bearvelt tube, there are a few little concepts that help me. The first is that you want to make a paracentesis 180 degrees away from the tip of the tube, okay? So if the tip of the tube is here, you want to have a paracentesis 180 degrees away. That's very important, okay? You want to insinuate into this paracentesis a pair of coaxial forceps that are serrated. They must be serrated. If they have smooth tips, they just slide right off the silicone tube. But if they're serrated, they will clamp onto the end of the tube, okay? So you want serrated forceps to grasp sort of this beveled cut part. And I try to take one tip of those serrated forceps and stick it into the tube, okay? So I'm grasping the tube by the wall. Okay, so I'm inside the tube and I grasp the tube with the serrated forceps and then I pull to put the tube on stretch. And that takes the tube, which is this cylindrical tube, and it flattens it into a ribbon. Okay, and the advantage of flattening the tube into a ribbon is twofold. The first is it makes it easier to get the scissors around it, because if you're trying to cut around some big cylinder, it's tough to really get good purchase. The scissors kind of want to slip off. But if the tube is squished down, it's much easier to cut, okay? So you grab the tube and you pull, and that tightens it and flattens it and makes it into a ribbon so you can get the scissors across it. And the other thing is that when you pull on the tube and you cut it, once you cut, what you have left over on the other side of the scissors retracts, okay? And what that means is that it allows you to cut the tube shorter than it would otherwise be convenient to cut it. Because if you have this big length of tube, you don't have to cut it all the way down here at the base. You can pull it and then cut it here in the middle, and then when it retracts, it'll be out of the way, if that makes sense.
Yes.
Now, one other sort of ergonomic point. You have the tube here. You have the paracentesis 180 degrees away. And the scissors that you use to cut the tube need to be 90 degrees away from both. In other words, you need to use some coaxial scissors through a main wound, which is 90 degrees away from the tube and 90 degrees away from the paracentesis. It needs to be right there in the middle, okay? That's where you want, and you want that wound to be large. You want it to be something like a 2.8 or a 3 millimeter wound as opposed to a 2.4 or 2.2. Because if you're trying to get these 19 or 21 gauge coaxial scissors through some 2.2 or 2.4 millimeter wound, it's really tough to work it. But if you have a larger wound, it's much easier to get those scissors through the wound. So you want a big wound that's 90 degrees away from each of these other two landmarks.
Yeah. So the forceps will be 180 degrees, and the scissor will be 90 degrees from the main one. Pull till it become squished, and cut it after that. Yeah, thank you very much for this. But like after he didn't probably he will do it the next time like this. He did the surgery, but he didn't do the way that you are. So like he didn't cut the tube. That's why I want to take your quick opinion before. After 4 weeks, it was attached and very well. And I remember you told me like usually it takes 6 weeks to the graft to be kind of confidence that it will not be detaching. But after 6 weeks, he just feels that he wants to see the patient again. He finds it completely detached in the AC. Do you do you think this is probably because he left the tube and this ergonomics like help with pushing the graft or something like that?
I wish I knew. I really do. I think a late graft detachment is really rare. Um, it's uncommon for a graft to detach if it's fully attached at 3 or 4 weeks. I mean, you usually think, okay, well, basically you're done at that point. And to have a graft attached at 4 weeks and then totally detached at 6 weeks is strange. I wish I had an explanation for that. I don't. But, the fact that the graft attaches at all is strange. I mean, the whole pattern is very strange. When I'm doing a DMEK and I see a patient the next day, almost always the graft is attached. Almost always the graft is attached, okay? Why would it be that 2 or 3 days later you have a detachment developing? You might say, well, it's because the air bubble is shrinking. And when the air bubble is shrinking, then you have less support, and so the graft is just not quite fully supported, and the bubble goes away and the graft falls off. And that makes sense, except it's not true, because in people who have no air in the anterior chamber at all one day post-op, the graft is still probably attached. And then at 2 or 3 days later after that, that's when you start to see the detachments forming. And I don't think anybody has a great explanation for that, why the graft would start to fall off after a couple of days. So who knows why some grafts attach and some don't attach? One thing I was just telling Garrett the other day is that we have a collection of patients in our practice who've had lots of DMEKs, okay? And these patients are typically those who have tube shunts in each eye, okay? There are many patients we see who have tube shunts in each eye, and if you have a tube shunt in your eye and you have a DMEK, the graft is probably not going to last very long. It may last a year or 2 years, but the survival of these transplants is impaired, and the DMEKs often have to be repeated. And we have some patients who've had 10 DMEKs because they have tube shunts in each eye and the grafts last a year or two, and we've been seeing them for 7 or 8 years, and they've had 10 DMEKs. They have a new DMEK every year. And there are some of these patients who've had 10 DMEKs, and we've never rebubbled them ever, okay? We've never rebubbled them ever. And there are other patients who've had 10 DMEKs, and we have to rebubble them 3 times every single time they have a DMEK. And the reason that this is interesting is because there are all of these theories out there about what causes detachment. Is it the graft? Is it the patient? Is it the surgeon? Is it all of these things? And my experience with patients like this is it's probably not the donor tissue. It's probably not the surgeon. Because there are some patients, you operate on them 10 times and the graft always attaches. And there are some patients you operate on them 10 times and you have to rebubble them every single time. And it doesn't matter whether it's me doing the surgery or my dad or Philip Dockery. It doesn't matter whether the tissue comes from this eye bank or that eye bank or how long the surgery takes. It probably is the patient. It's probably something about the patient itself or themselves that contributes to detachments that we just don't understand.
Yeah, so that anyway will not change because this is something not common. That was his question. It will not change our follow up. Like we'll not see the patient every week forever. Like I
Yeah.
think 6 weeks is the critical time. After that, we can see after 3 months or something like that. That's what we think.
The way I was trained was 1 day, 1 week, 1 month, 3 months. That's the way that they do it
Yeah,
at the Neos. And
yeah,
so,
yeah.
yeah.
I'm following this way as well that you told me about.
Yeah.
So, Dr. Jack, I know that you still having a clinic, and I have loads of questions. So, it's 40 minutes already. So, I promise it will be 30, but like it seems that you were very generous to give me more 10 minutes. Thank you very much for that, Dr. Jack. And I was always very happy to see you and to hear from your learning points and tips. And definitely, we will make a regular podcast and definitely we'll see you in London soon. Um, uh, First, there is SCAIRS in London, but hopefully we'll see before the SCAIRS in London
Yeah.
for this course, because that will be a great idea if we start this manual CAIRS that I think you are one of the pioneers in the world in it, and we'll learn from you.
Always so nice to talk with you, Hosny. Look forward to our next one.
Yeah, thank you very much, Dr. Jack, and I'll see you very soon in our next podcast. Thank you very much.
Thank you.